So we're going to get started here. I'd just like to introduce myself. I'm Dr. Jason Hafron. I'm on staff at Beaumont. I'm Associate Professor of Urology at Oakland's University William Beaumont School of Medicine. I first want to thank Men's Health Organization, MIU, Michigan Institute of Urology, Run for the Ribbon. Michigan Institute of Urology is one of the largest practices in the U.S. for men's urology, and we've set up a fund as a 501c3 nonprofit organization to raise awareness for men's health, develop programming within Southeast Michigan to teach men about health and prostate cancer and health-related issues specific to men. A lot of this money has been given by our foundation, and we actually have a race every year on Father's Day. I don't know if you've seen it in the press, but we just had our race Father's Day at the Detroit Zoo, and we had over 2,000 runners come show up. And the picture there is all our survivors. At the end of the race, we get all the prostate cancer survivors together to take a picture, and this is from last year's race of all the survivors that participated. And so I have to give my thanks to MIU, Run for the Ribbon, Health Foundation for support of this programming. What I'm going to talk to you today about is the history of robotic surgery. It's kind of an interesting history. I've been doing robotic surgery for almost 9 years, so it's kind of become, standard of care in many institutions. I've kind of, everyone looks at me as young, but I've pretty much grown up on these procedures. So I've seen the evolution to where we are today, and it's quite impressive. And we can't talk about robotic surgery without talking about Da Vinci surgical systems. Da Vinci is the pretty much the only robotic system we're using in the U.S., and I'll go into that. And then I'll touch on some of the robotic procedures we're doing today for men's health with a specific focus on prostate cancer. If we want to talk about bladder cancer and robotic surgery, I'd be happy to talk to you about that as well. And then the future of robotic surgery, what's coming down the pipe and what we are working on for the future. The history of robotic surgery is interesting, and it starts with where the term robot came from. It actually was coined by a Czech playwright, Karl Čapek, in 1921. And it was in his play, Rossum's Universal Robot. And the word robot, and I just learned this putting this together, is basically from the Czech word robota, which means forced labor. And that came out in the early 30s. Where robotic surgery developed into health and where it started was this is the first robot that was used. It was the Puma 560. And it was started in 1985 by Dr. Kwa. I think he was out of California, and you can see on this picture that it would basically, what they were trying to do, that gray thing, it doesn't project well, was trying to do what we call stereotactic brain biopsies. So they would manipulate the arm to get extreme precision and actually, take a biopsy of a lesion in the brain, and then using lasers to cut that out. And that's where robotic surgery, the first report of robotics used in the operating room. I don't think this robot is still being used, but it's basis for all future robotic surgery. The next robot that we saw actually came to urology, and this was in England at Guy's Hospital in the early 90s. And what they were doing was robotic TURPs, transurethral resection of the prostate. A lot of guys have heard of that. It's the rotor-rooter procedure. As men age, their prostates grow. Sometimes you have to core out that prostate. So what these guys did at Guy's Hospital was essentially develop a robot that could mechanically rotor-rooter the prostate and open up the prostate so men could easily urinate. The problem with this robot was that it's very hard to image the prostate, so they couldn't really tell the limits of the soft tissue, so it really didn't go that far, and it kind of just died in its tracks. So we didn't see it. But one robot that's being used, I don't know how widespread, is the Robotic, and that was the next robot that was essentially used in healthcare. And it basically was a machine that was used for fractures. You hear in orthopedic fractures where they put pins in or they put hardware in. And what this robot did was basically just drill a hole into the femur bone, and with robotic technology they could control the diameter, the depth, and be more precise. So the Robotic was the first commercially available robot used, and it is still used in some centers, and it just allowed precision for the orthopods, for the bone guys, to put in this hardware. The next robot, which I actually, obviously I'm not that old, but what we used, and I actually used in the start of my training, was a robot called ESOP. And ESOP was the first commercially available robot used specifically for laparoscopy, for minimally invasive surgery. And it was basically, as the name is an acronym, for Automated Endoscopic System for Optimal Positioning. The system was initially designed for the U.S. military, but went into commercial production by a company called Computer Motion out of California. This was the first FDA-approved surgical robot, and that was 1993. And the way this robot worked was basically it held the camera for while we operated. And using this machine, it was a good machine. It worked, it served its purpose well. And basically you could talk to ESOP or to the robot and tell the robot to move the camera left, move it right, move it in and out, which essentially freed your hands to operate. So you didn't have to rely on an assistant. You could control the actual camera. You can control the picture of what you were seeing during the operation. ESOP was great, but it was eventually bought out by Da Vinci Surgery and is not commercially available anymore. The basis for modern robotic surgery, what we're using today, goes back to the military, and it started in the Vietnam War. Basically, the theory of the golden hour. The golden hour was this, and this seems, you know, standard of care now, but what they learned based on the injuries in Vietnam was they basically had 1 hour to get the soldier from the battlefield into the operating room, okay? And this was revolutionary at the time. It's the basis for all trauma surgery that we use, you know, at Beaumont today. And when they started reviewing the deaths in Vietnam and the traumas, was that they found that basically, and this is a rough estimate generalization, 1/3 of the soldiers died just because of massive injuries. They weren't salvageable. 1/3, though, of the patients died of insanguinating or heavy blood loss that probably could have been salvaged if they had early care and were controlled. And that 1/3 of the patients that had heavy hemorrhage in the battlefield is the basis for and the impotence for robotic surgery of what we're doing today. And then 1/3 survived. So I want to focus on that 1/3 that had the heavy blood loss in the battlefield. And what the Army took with that data is the concept of telepresence. And what they did was they basically, and this has never been used in war, but they basically wanted to develop a Bradley fighting vehicle where they could basically take the soldier off the battlefield and put him into this vehicle and start surgery. Okay? And the way that they could start surgery was, if you can't see it well, this is the only picture I have of this vehicle, is that they would have a robot literally in the vehicle where the surgeon would be, you know, off the battlefield and could start, you know, treating the soldier and stop these heavy blood loss. And so that, in 1996, the Army put a ton of money into developing this telepresence where they could basically perform telesurgery. And they've done it, the Army has done it in animals, and they've done it over a 5-kilometer distance, accounting for the delay in the transmission of the signal. They've done it in animals, but never in human, and as far as I know, who knows, it's never been clinically tested or used on the battlefield. But that was the basis for robotic surgery. Can we operate on the soldier in the field by a surgeon in a hospital or somewhere else out of harm's way? So one aspect of modern surgery went to the Army to develop telesurgery. The other commercial aspect of it went into cardiac surgery. So there was a company, and this is Dr. Fred Moll, the guy who invented Da Vinci surgery, and that's a picture of him in the early days, is that they wanted to take the robot and operate on the beating heart. Okay? If they felt that the robot could overcome the motion of a beating heart by gating it or by controlling this rhythm, they could operate on a heart without putting the patient on bypass, with all the morbidity associated with that, and without the large sternotomy or the big sternum incision, put in a few trocars, a few ports, and operate on the beating heart. That, in theory, would have revolutionized cardiac surgery. Problem is, it didn't work. They couldn't really account for the motion of the heart. The computer couldn't assess that, and it really never took off. But that's where Da Vinci has come into play now, is that essentially, and this is the modern robot that we're using today, this is the SI system that most hospitals are using, is that the heart didn't work, but then it was picked up in the prostate. And that's where we're seeing most of the surgery done today. And in the future, and I'll show you, it's expanded to other surgical procedures. So what is the Da Vinci surgical system? It's basically a system similar to this telepresence where the surgeon is operating away from the field, but still in the operating room, okay? We're not doing it over the internet. We're not doing it over a phone wire. We're literally in the operating room next to the patient. And with the advantages of Da Vinci surgery or robotic surgery is that when you're operating, you're immersed in this 3D high-definition surgical field with 10 times magnification. You literally see things you can't see with your own eye. And the surgeon essentially directs every move of the operation. It's a slave robot. We sit at a console and are able to operate. It's not like we punch in the coordinates or tell the robot, take out the guy's prostate. We actually are doing the operation. So it essentially replicates the motion, but the nice thing about robotic surgery or robotic assisted surgery, it takes away the tremor, okay? There's no tremor. It actually, and then the instruments themselves can move in 6 degrees of freedom, which is more than the human hand can do. So you can actually do literally surgery that you couldn't do with your own hands. And that's a combination of the excellent vision as well as this tremor-free directed placement of your instruments. And here's just a quick animation of how it works, just to give you a picture. The surgeon sits at the console, and you can see him operating there. The patient's on the bed, and then we dock the robot. While the patient's sitting at the console, he sees the surgical field. The camera shows him what's going on, and then we literally operate through these pincers or through these graspers. And as we move him in space, how we move mimics what the instrument is doing. And as you can see, you can move it pretty much in any direction with computer-assisted, tremor-free motion. And that's the basis of how these systems work. It's a slave robot. We control everything it does. And just to show you the capabilities of it, this is one of the early films. I always loved this film because it shows the dexterity and the ability of these machines. Here's basically the robot, obviously in a lab, doing origami, the Japanese folding of the paper. And you can clearly see with this small piece of paper how much precision and control you have. And these are just standard working instruments that we still use today. But what's impressive is the scale or the magnification that we see when you fold this up. And you'll see at the end how small this little piece of paper really is. So I think
2 people operating or what?
It's one person operating at the console, and it's one person at the table side, an assistant. Okay, they're essentially passing the instruments. Here I think he's making a swan of some sort. This is from a Japanese group. But you'll see at the end, beautiful swan. But just appreciate how small, he's flying the swan through space. But at the end of this, you'll see literally how small this was. It's the size of a penny. So just to put in perspective what kind of dexterity or control you can have, that's really what the essence or the ability of the greatness of robotic surgery. So the first robot, I'll just show you this map, came in 1999. I don't know how it projects so well. Ohio State got the first one in 99, and a group in North Carolina, I'm not sure which university got it. And that's when the first commercially available systems were put into play. And what you'll see over the years, more and more systems were put in. Beaumont and Henry Ford got their system in 2001, 2000. Cleveland Clinic picked up, where I came from, picked up their system in 2001. But as you'll see, over the years, and this is courtesy of Da Vinci Surgical, how many systems have come into play that basically they're pretty much all over the country, to the point where there's 30% of all U.S. hospitals have a robotic system. Okay, so they're pretty much everywhere. And it's become, like what I tell my residents, anything good in medicine permeates through. There's no secrets out there. It runs rampant. And basically, in less than 10 years, a third of U.S. hospitals are carrying this system. So it clearly works, because otherwise this wouldn't have taken off like it has.
Who builds it?
Da Vinci Surgical, out of Sunnyvale, California. Cleveland Clinic, again, where I came from, you can see the presence that robotic surgery has. Cleveland Clinic has excellent marketing, hospital. when President Obama came to visit, first thing they showed him was the robotic system. And as you see on the news, it's basically become everywhere. Here you can see actually President Clinton working on the robot, but it's picked up on CNN, it's on US News, it's everywhere. Robotic surgery has really taken off, and the reason why it's taken off is because of the quality of the surgery that we can do, the successful patient outcomes that we've had. And it's made it, Grey's Anatomy, doctors, you name it, the robot's been in some sort of media circle. So let me shift gears. That's this, essentially the history of where we came from. It's basically driven by the military, like all good things, and brought into commercial use. What I want to focus now on is the procedures that we're using today. How are we helping men across the U.S. with robotic surgery? And you basically have to start with the prostate. And I'm just going to go give you some background on what the prostate is and what does it do. But basically, the prostate is the male sex gland. It adds nutrients and fluids for sperm. It's basically, we need it for fertilization. It prepares the sperm to fertilize an egg. And it's basically the red thing just below the bladder, and it runs through, or the urethra is a channel that runs through the prostate. Okay, so you can see it on that slide. Again, it's the red, walnut right below the prostate. You guys see it? Okay. What is prostate cancer? Prostate cancer is abnormal cells growing out of control. It begins in the prostate gland. It doesn't begin in the bone. It doesn't begin in the lymph nodes. It starts in the prostate. And as you can see in this picture, the cells grow out of control. The prostate enlarges, and it can spread to other tissue, organs, lymph nodes, bones. But it always starts in the prostate. How common is it? Here's a question for you guys. How common do you think it is? How many men are affected by prostate cancer in America? You can answer that or not. If you guys, any guesses? A? B? Depends on the age. Overall, across the board, regardless of age. 1 and 3, so A. So we've got a couple A's and a couple B's. It's actually B. 1 out of 6 men will develop prostate cancer. It's actually more common than breast cancer. Even though we see breast cancer gets a lot more press, more men will develop prostate cancer than breast cancer. And what that translates is it's the second leading cause of death in men. Okay? And that gets lost a lot, especially in the recent literature about PSA screening. It's the second leading cancer death behind lung, okay, in men. Every 2.5 minutes, a man is newly diagnosed. Every 16 minutes, and this is kind of scary, a man will die of prostate cancer in the U.S. Okay, so it's pretty alarming numbers. So the next question is, am I at risk? What are the risk factors for prostate cancer? Who's going to develop it? And age, like you said, is definitely a risk factor. But one of the myths is it's not only an old man's disease. Okay, that's completely not true. Risk increases with age, that's definitely true, but men of all ages should know their personal risk factors because it's not always the old man. And what are the risk factors? Age, like we talked about, family history is very important. Father, brother, or son, if you had a family history of prostate cancer, you're generally twice as likely to get it than the next guy next to you or the average guy. Race is also a very important factor. African American men are more than twice as likely to die from prostate cancer than white men. And that's true even when you exclude access to care. There's definitely some genetic basis to African American prostate cancer as a worse disease than non-African American men, and once you exclude social issues. So race and family history and age are the 3 big ones that are the risk factors for prostate cancer. What are the symptoms? They can be trouble urinating, weak flow of urine, frequent urination, especially at night, painful or burning urination, blood in the urine, blood in the semen, pain in the back, hips, or pelvis. That's usually at a more advanced stage, or painful ejaculation. But what's important to know, if you don't have the symptoms, you don't have prostate cancer. That's a myth. Maybe it's true, but what I see in my clinic and what I see in my practice on a day-to-day basis, most men, or not all men, experience symptoms with prostate cancers. Usually we, the urologist or your primary care doctors, are the first ones to detect the signs and symptoms of prostate cancer, namely the PSA. Okay, and I'll go into PSA as it has become more recently a controversial issue within the media. Who should be screened and why should you be screened? The AUA, which is the American Urological Association, which is the association that we follow, it's our national organization, is basically recommends that you should talk to your physician, urologist, primary care doctor, about a baseline screening for men starting at age 40. Okay? If you have risk factors, African American, family history, you probably should start definitely at 40. But it's a discussion that you need to have with your urologist or your primary care doctor. Why do you want to know this? Because if you do have prostate cancer, it's easier to, or why do you want to know your PSA? It's easier to identify changes later. So if you have a PSA at 41, that's 1, and 6 years later it's 3, something happened. There's been a change. So it's important to get that baseline study. And what's most important, the overlying principle is that early diagnosis leads to more treatment options. The earlier you get it, the better chance of cure and the better choice you have in how to treat it, the more options you have available for you. What does screening involve? What is screening? It's basically a blood test, the PSA. Okay? We all know about it or heard about it. If you haven't, let me know. And the digital rectal exam. That's what we have right now. There's a lot of research going on and looking at new generation PSAs. I'm not going to go into that, but that's a very hot area of research right now in urology. And then to diagnose prostate cancer, we typically order biopsies if you have significant risk factors or if your PSA or digital rectal exam is abnormal. And that, again, is usually if the PSA is above 2.5 is a generalization, you're at increased risk of prostate cancer. So when that PSA is high or is rising quickly, that's a red flag to investigate or to discuss this further with your physician. And once we do a biopsy, well, let me just throw out another myth. High PSA, and this is kind of touches on the controversy with PSA, just because you have a high PSA, let's say you have a PSA of 6, that does not mean you have prostate cancer. And that's one of the weaknesses of PSA. It's a good test, but it's not perfect. It lacks specificity. A low PSA generally means less risk of cancer, but doesn't mean absolutely you have no cancer. Okay? High PSA could be because of prostate cancer, but it could also be because you have inflammation, irritation. You can have an enlarged prostate gland or other conditions that can cause this PSA to go up. However, on the same side, low PSA does not mean you don't have it. It doesn't mean you're home free. A big or sudden change in PSA could also signal trouble. If your PSA goes from 0.5 up to 1.3, that can even be a sign of prostate cancer. PSA is a good test. It's not perfect. You really have to look at it on a case-by-case basis because it's not a yes or no kind of answer. It's not always clear. So once you have a PSA and once you talk to your doctor and you think you're going to go for a biopsy, the way that we diagnose prostate cancer is by a biopsy. It's basically a thin needle that removes usually 12 samples of prostate cancer tissue. And once we remove it, we use what we call the Gleason score. It's a grading system to grade the aggressiveness of this cancer. How bad is it? And you can basically see on the top of the slide is the least aggressive, and it's very tubular. But as you get more aggressive, it loses its tubules and becomes more differentiated, and that's the more aggressive. And this is the classic picture that we use to train our residents and the pathologists use to grade the cancer. Each one of these pictures has a number. And basically, you add the two scores together, and that gives you the grade of the cancer, and that's the Gleason grade. An example would be Gleason 7, which basically is a 3+4. What does that mean? When the pathologist, the guy looking at it in the microscope, what he sees the most of is 3. 3 is this middle slide, in the middle picture. What he sees second most of is a 4, and that's just how the cells look under a microscope. And that's the Gleason grading system after Dr. Gleason. So that's one part of the prostate cancer diagnosis. The other is staging. And staging is the extent of the tumor. Not that we're going to get tested on this, but there's basically you may have heard this, T1, T2, T3, T4. T1 and T2 are basically localized prostate cancer. They're in the prostate gland. T3 has actually, as the bottom left corner shows, has actually started to make its way outside the prostate, and that's a higher stage, a worse prognosis. And T4 is when it completely spreads outside the prostate. This is similar, general T score is similar for all cancers. It's just the extent of the disease, not based on the grade, just how much tumor and how far it's gone. So what are the treatments for localized prostate cancer? There's basically 4, and there's some other ones that are out there, and I'll touch on them. There's active surveillance. And then what that means is there's active monitoring of your prostate. What I term active surveillance is linking the treatment to the timing of the disease. If the disease is not significant or it's a low-risk prostate cancer, we might just watch it and just see what it does. Over time, if it gets worse, we might advocate treatment, but we can follow that. And how do we do surveillance? We basically monitor your PSA, your blood test, your digital rectal exam, and we'll also do a biopsy, usually every year, but it varies. As we get further out, we do it less and less. Radiation is another mainstay of treatment. It kills cells, but it does not remove them. You use radioactive energy to treat the prostate gland. It can be external beam energy from outside, or something that a lot of people have heard of, seeds, where we put radioactive little, like rice pellets, into the prostate gland, and that emits radiation. The radiation itself will kill the prostate cancer cells. Surgery, which I'm going to go into more detail, removes the prostate and the cancer cells. We can do it now minimally invasively, robotically, or 10% of all prostate cancer or prostate surgeries are done the old-fashioned way, open. There's other stuff, cryotherapy, HIFU, nanoknife, some other new therapies that essentially are ablative technologies that inhibit or kill the growth without removing the gland, similar to radiation. So what is surgery? And here's just an animation. Basically, we're going to go focus on the prostate gland, and we use those instruments that I showed you a few slides ago and remove the prostate. What those yellow lines that you see are the nerve bundles. Those are the nerve bundles that actually control your erections. And so the skill or the challenge of prostate cancer surgery is to remove the prostate gland from the bladder and from the urethra, which is at the base of the prostate, without injuring the nerves that run alongside the prostate. You injure the nerves alongside the prostate, the guy's going to be impotent. His quality of his erections is going to go down. So using various instruments, we are able to detach it from the bladder, detach it from the urethra, detach it or separate it from the nerves, which this computer animation is showing, and then go ahead and take the gland out. Okay? Once we take the gland out, we literally take the bladder and sew it back to the urethra over a catheter. And this is where robotics shows its true greatness, is that the skill, you're literally sewing 2 pieces of spaghetti together, and we can do that because we can see well and we have computer-assisted motion. We do it through five holes in the body, okay, and that's what this picture is showing. And we put those instruments through there. One port is the camera, the other are the working elements.
Where does the discarded gland go?
The discarded gland comes out through the belly button, and it doesn't pick up well, but there's a little black little incision just below the belly button where we can pull it out of there. About a walnut size, but it varies. Sometimes we can bring out, plums or peaches, bigger glands as men age or the cancer is worse. So again, radical prostatectomy, the surgery is total removal of the prostate gland. The AUA, again, it believes, based on 2007 guidelines, this is a major potential benefit because the cancer is removed. And it's a nice way to treat it because you're removing cancer in a localized spot, okay? And that's where prostate's indicated. One of the caveats with doing surgery is that when we remove these glands, 30% of the time or a third of the time, the cancer is worse than we had anticipated based on the biopsy. So that's why I prefer surgery for treatment of prostate cancer, because once we remove the prostate gland, we know exactly how much cancer. We know the exact stage, the exact grade, so we know we can tailor our treatments. Sometimes surgery alone is not going to cure you from this disease. Sometimes we may use radiation or other agents to cure you from this disease if the pathology report or if the cancer looks much worse than what we saw in the biopsy. Another advantage of surgery is what I talk and counsel my patients day in and out is, what if the cancer comes back? Okay, you always got to think worst case scenario. You know, essentially we have one life, so we got to really think about worst case scenario. If the cancer comes back after surgery, it's very easy to follow a patient to detect a change, to detect a recurrence. PSA is a good test. It's even a better test after the operation. Take out the prostate, PSA should be 0. Any minuscule elevation of that PSA indicates a return of cancer. Okay? So knowing that it should be 0, if we see, you know, a thousandth of a click up, we are suspicious and we can jump on a potential recurrence. The problem with radiation is that you never 0. And radiation PSAs can fluctuate. The prostate's not removed, and the PSA can go up and down, and the prostate can still grow. So it's a little more challenging to follow a patient, okay, following radiation. The other option, too, is that if you're treated with surgery first, you can always do radiation later. Okay, that's an important point. If you do radiation up front as your primary treatment, you can't typically do surgery afterwards. Okay, the radiation will literally scar the prostate into place. We do it, I do it, it's just associated with much more morbidity and potential complications. So what I tell or counsel my patients in the office is that, God forbid it does come back and you've had surgery as your primary treatment, you have more in your back pocket if you need to use it. Okay? So I think that's an important point, not always discussed or patients are aware of when I see them in the office. So let's talk about, this is a talk about robotic surgery. Let's talk about minimally invasive robotic-assisted prostate surgery. Why are we doing this? What's the advantage? And basically, we get excellent cancer control. We're starting to see a faster return of sexual function. Again, more precision, more precise ability to control those nerves nicely. We're definitely seeing a faster return of continence. Guys dry up. They leak less after this procedure. Shorter hospital stay. After the surgery, you stay one night in the hospital, you go home the next day. Pain is really not an issue. Again, with precise surgery, you see it's less traumatic. Patients heal very nicely. Less blood loss. It's rarely, or if ever we ever have to transfuse a patient, give them blood. There's a low risk of infection and complications. Recent literature has shown that this is even safer than the open surgery. Okay? And a faster recovery and a return to normal activity. I just had a patient I operated on a few months ago. I operated on him last year. 3 weeks after the surgery, he literally ran the Detroit Marathon. I mean that just shows you that this guy was an extreme case, but it shows you the capabilities of robotic surgery. The other thing is the smaller incision. As you can see in the picture, the open surgery, you have a large midline incision. With robotic surgery, you have these small, tiny little keyhole incisions. So let's talk about urinary incontinence. Here's an old video I had from one of my surgeries where it shows how, this is actual footage of a patient. Here's the prostate's removed, and we're sewing again that, I showed you that, we're sewing the bladder back to the urethra. And you can see here why it's important to have that type of control and how small of a space we're working in. So here we're using suture or string, if you want to call it that, sewing the urethra back to the bladder. We'll put 10 to 12 sutures in this spaghetti tube and bring it back together. Clearly, robotic surgery is the answer and the correct way to do this. You don't have to be a surgeon to see why you need that kind of precision and control and vision. And here we're just I'm sewing it back together, and then we'll tie a knot and put the catheter back in, and this is pretty much the end of the operation. This is actually a couple years old. We've done some changes recently, but it's just basically the same concept. Kind of give you a flavor of what we're doing during the operation. And that yellow thing you see in there is the catheter, and that's the tube that comes out of your penis that we sew, or the splint that we do the repair over. Any questions? The question is, what's the catheter? Where's the catheter coming from? It originates from outside the body. It's inserted through the penis into the bladder. So it's a tube that hangs outside the penis.
So it's not hooked up to a bag?
On the outside it is, yes.
Oh, so you're going to have a bag?
Yes. You have a bag for 7 days.
7 days. And then after the 7 days, what happens?
We remove it.
The catheter?
Yep.
Okay. And you can urinate as normal through the penis?
At first, you'll have some leakage, but you'll urinate through the penis, yes.
Okay.
Okay.
Just follow up, so the catheter is basically acting as a scaffold for the tissue?
Yeah. The question is what purpose does the catheter serve? It's essentially a scaffold or a splint to allow that tube to heal over. Okay. So it's like you break your arm, you get a cast to put the bone back together. This is a tube to allow the tube to heal over. And we found in 7 days with robotic surgery is the adequate time for this to heal. So let's talk about sexual dysfunction and the nerves. You know, this is a hot area. Here's a recent picture of one of my surgeries where I'm doing a nerve dissection. Here you'll see in this video, I put those white things are clips, okay? What we've learned is that we don't use cautery or any energy to dissect the nerves because neural tissue is very sensitive. We don't want to put energy near that, heat or any type of energy. And what I'm doing here is, as you can see, is separate. The prostate's on the right is flushing the nerves off the prostate. And you'll see I'm just using a scissors and just cutting that away, the nerves, separating or peeling the nerves off the prostate. And as I move further along the prostate, that whole sense of tissue, or that whole tract of tissue, is the neurovascular bundle. So you don't really see nerves, you just know where they are, and you want to atraumatically peel them off, like peeling an onion off the prostate. And that's how we essentially do a nerve dissection. Okay, and that's the basis of prostate surgery. The two biggest side effects are incontinence and sexual dysfunction. And I just want to give you a slice or a picture of what we're doing or trying to do during this operation. What I'm going to switch gears and talk about another procedure is a robotic partial nephrectomy, which is for kidney cancer. Kidney cancer is the 6th most common cancer. It's not as common as prostate, but it's as 6th most common cancer. And it basically is the most, renal cell carcinoma is the name of the cancer, and it typically occurs in men aged 50 to 70. The exact cause we don't know. Smoking obviously makes it worse, but what do patients usually develop? They usually develop abdominal pain, swelling, back pain, blood in the urine, swelling of veins around the testicle, which could be what we call a varicocele, flank pain, or weight loss. That's how these symptoms develop, and it's usually a tumor that grows out of the kidney. What with robotic surgery is that we can remove these tumors pretty easily without a large incision. When I started my training, we'd make these, I call them shark bite incisions, large incisions with removal of the rib, which was pretty morbid. These guys were pretty miserable for months after the operation, to putting about 4 or 5 small incisions and going ahead and incisions the size of my finger, and going ahead and removing the tumor themselves. So here's basically I just want to give you a taste of what robotic surgery is for the kidney. Here is the renal vein and artery that I've identified in this kidney, in this patient. The artery's on the right, the vein is wider, it's on the left. The first part of this operation is identifying this, okay? Is skeletonizing or exposing the vein and the artery. And I'll show you why that's important. This is what we call a partial nephrectomy, where we're just removing the tumor, not the entire kidney, which is important and is slowly becoming the standard of care. Here's the actual tumor. It's kind of a small picture, but you can see that I've started, and this is pretty unedited, I just roughed this in last night, but that's the tumor, kind of that ball sticking up. Okay, I don't know how well you can see that. Once we have identified the tumor, we've defatted the kidney, we'll actually stop the blood flow to the kidney. And we have these clamps, we call them bulldogs. We'll put these bulldog clamps and stop the blood flow to the kidney. Here you can see we're putting it right, that's a clamp on the artery. We'll put also a clamp, I don't know if this video will show it, we'll put a clamp on the vein, and we'll stop the blood flow. What that allows us to do is to cut into the kidney without significant blood loss. The kidney is a very vascular organ. And this is live pictures of an unedited surgery of mine just a month or 2 ago. Here we're putting a clip on the vein. The vein's the wider, bigger thing. It's much more compressible. And we're basically making the kidney ischemic, okay? We have 30 minutes to work on this kidney, okay? That's the allotted time we have to fix this. I like to put 2, I don't know if this shows it, I don't remember in this video. I put a second bulldog just to make sure that this kidney's not getting any blood flow. Sometimes the bulldog's weaken, so we double clamp, or I double clamp the renal artery. Okay, so we've clamped the kidney. We have 30 minutes to get this tumor out. So I go back, camera up, go back up to my tumor, which we'll see here, and start literally cutting the tumor out. Okay? And what you'll see in this video is I'll just use my robotic scissors or shears, I call them hot shears, and start just cutting the tumor out. And the nice thing, there is some blood here, but it's pretty minimal. If this wasn't clamped, the blood would be squirting. We wouldn't be able to see anything. This is kind of just some venous oozing. It's not really a big deal. And literally just chomp, 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 cut the tumor out. Okay? And we sometimes have to use ultrasound or other imaging to define the borders of it. This one was a small one, so we know how, essentially I know how deep to go, and we'll go in and just cut out this golf ball tumor. The nice thing about this operation is that I can basically preserve 80% of this guy's kidney. Okay, so he'll have 80% of a functional kidney. Robotically, he'll have less pain, less blood loss, and this guy went home the next day. I mean, it's amazing. So here you can see, I don't know again how well it projects in the back, but you can see that here I'm getting under the tumor now and starting to peel the tumor off the kidney. So, okay, and that's what we're doing. It's a pretty bloodless field. You know, it's not perfect because there again is some venous oozing, but we literally just cut this tumor out of the kidney.
How do you stop the blood flow to the prostate?
The blood, we know where the arteries are, and those white clips I showed, we just clip the arteries. But the prostate's coming out, so we can permanently leave this. I'm leaving this guy's kidney, so I have temporary clamps. Those bulldogs are temporary clamps that I'll take off and reperfuse the kidney. Okay? I don't know how long this runs, but I'll keep cutting this circumferentially and getting the tumor off. Yes?
I'm going to ask a question. Probably not supposed to. Are you controlling the camera
at
the same time?
I'm controlling the camera with my hands and feet. I have control of everything in this picture.
And this will sound really stupid, but isn't there other tissue? I mean, it looks like you're wide open and there's nothing around this. Just to spare us the details, I've edited out a lot. You basically have to remove, mobilize the colon out of the way, have to defat the kidney, and expose this. So there's a lot of exposure. Okay, to get to this point is probably an hour's worth of work. Okay, I don't know why the video stopped, but after we remove this kidney, then we sew it back together. Okay, and we have special sutures that we can sew this kidney, sew it, in we call it a baseball stitch, and basically compress it so it won't bleed. Unclamp the kidney, reperfuse the kidney. Kidney's perfect. 80% of the nephrons are spared. Guy goes home tomorrow. He's cured of his cancer. Doesn't require chemotherapy. Doesn't require radiation. He's done. Amazing. It's truly amazing. Another procedure that is kind of taking foot and is very new is the vasectomy reversal. Okay, this is new. I don't know if it has been done in the state of Michigan yet, but my partner Rick Bennett, who's a specialist in infertility, is going to start doing these procedures probably by the end of this year. And basically, let's take a step back and start with a standard vasectomy. We all know what we get vasectomies for, so we don't have children, or you're done. You don't want to have any more kids. And basically, what a vasectomy is a form of birth control for men that's meant to be permanent. Okay, it blocks the tubes that carry the sperm, and when the tubes are closed, sperm cannot leave a man's body and cause pregnancy. So it's an office procedure. We basically tie off the tubes. I don't know. I'm sure a lot of guys have already had this. And that's essentially what a vasectomy is. It's been around for thousands of years. Sometimes guys, remarried, whatever, want to reverse it, okay? And what we try to do when a guy reverses, again, I don't do this, my partners do, is that we'll either reconnect those cut tubes or we'll take that tube and connect it back to the testicle so that the sperm can come back out. Typically, this is a microsurgical procedure. It's done under using a microscope. One of my friends and colleagues, old colleagues, has started doing this robotically down in Florida. And my current partners, we're going to start doing these cases here in Michigan. What's interesting is I don't know how well this projects again, is basically that's the guy's scrotum, okay? And we basically dock the robot in space and do the surgery on his scrotum. We're going to reconnect that tube, or take that tube and reconnect it to the testicle. What you don't realize is when they're doing this surgery, the suture is lit, and this is a video, a very short video, it's a pretty new procedure.
The suture is the size of a human hair, okay? It is so fine that you can't even pick it up with your fingers, okay? Here you're seeing, this is literally human hair-like sutures that they're using to reconstruct this. When they sew this tube back together, they do it in 3 layers. So you can imagine or understand why we would want a robot to do this. New, very expensive. Its future role we don't know, but it's one of the newest procedures, and I anticipate in the coming years it will become one of the hottest procedures we'll see in that instance if you're interested in a vasectomy reversal. I mean, I'm sure not a lot of you guys here today are interested, but it's just the capabilities of this technology of what we're seeing. So those are kind of the basics, or what we're using the robot today. What I didn't touch on, and I've spoken to a couple guys, is robotics for bladder cancer. We're using a lot of it for bladder cancer. We don't do open bladder surgery, rarely if ever, try to avoid it. With robotics with bladder cancer, we can do a pretty invasive operation with minimally invasive technique, and where patients just fly. It's a great operation. I could show you a video at another time of that. I do a fair amount of those surgeries as well. So the question was, if you have a bladder tumor or bladder cancer and it's blocking your ureter, or the tube that drains your urine from your kidney, how do you remove it? Usually the tumors are within the bladder, inside the bladder. So if you remove the bladder, you'll take away the obstruction.
You mean the tumor?
The tumor. So you take out the whole bladder, the tumor's inside the bladder, and you unplug the ureters from the bladder. You take those ureters, the tubes that connect the kidney to the bladder, you can plug them into a bag, or you can create a new bladder out of a small bowel and reconnect that back to the urethra.
Okay, so your surgery is actually removing the bladder.
Correct.
It's not just removing a tumor.
Typically, and this is a generalization, you got to look at a case-by-case basis, most tumors, bladder tumors, if they're invading into the muscle, we typically remove the entire bladder. There are special instances where we'll remove part of the bladder and leave some of it behind, but it's more of a unique situation or a specific situation than the usual. So it can be done, it just, you got to look at, every case is different.
So you're hooked up to a bag, and therefore you no longer urinate through your penis.
Correct.
And where does that bag go?
The bag the question is, where does the bag go for bladder cancer? It attaches to your body. So you take a piece of, once we remove the bladder, we'll take a piece of bowel and attach it, and what we call a conduit, attach the ureters. The ureters will be to this bowel, and it will stick out like a stoma, and there'll be a bag that you attach to your body, which will collect the urine.
And then you have to empty that bag.
You empty that bag, correct.
Okay. And how often do you have to go back for, like, retreatment on the bag or the?
The question is, how often do we have to go back for a retreatment on the bag? Rarely. Usually it's fine. The bag is a very secure, traditional, the least complicated way to divert the urine.
What's the capacity of the bag?
Bag is about 400 or 500 cc's, so you're going to basically, it's like the bladder. You're going to empty it a few times a day. And how many times you empty it depends on how much you drink, so it varies. Okay. So let's talk about new technologies, and this is, as a robotic surgeon, we're always looking for what's coming tomorrow, what's new. And one of the newest technologies is we're seeing collaborative surgery. So Da Vinci Surgical has a dual console machine where we can operate with another surgeon. There's going to be interfaces in the future where we can do collaborative surgery, where we can have a couple surgeons working together. We see one console, one surgeon. There's going to be interfaces where we can have multiple surgeons working together on the procedure. So collaborative surgery is something that Da Vinci is researching and developing the technology. Skill simulation is a big thing now, especially when you're training new doctors, residents, or doctors in the community how to do robotic surgery, where it's basically a video game, where it's video Olympics, where you're, tying things, suturing things, moving a ball around, and that's how we train our residents now, is that they'll go on the simulator and practice, get their skills, before they come to the operating room so they know how to use the device. And it's essentially a video game. And we use that a lot, and it's now required for all our residents as we train them. A new thing, too, that's already out is in imaging. Imaging is going to be the next breakthrough in surgery, is using image-guided surgery. How can we use X-ray? How can we use ultrasound? How can we use MRI to direct us or to improve the precision? This is one example. They call this Firefly. It's basically you inject a dye, change the waveform of the light that we're using, and we can actually see tumor and non-tumor. So the green is the normal kidney. The white area is the tumor. So you can go back to that slide I showed you. I didn't have Firefly, but imagine I had a dye where I could actually see the tumor, so I knew basically where to cut. And it can even identify where the artery and veins are. So it kind of makes surgery simpler by using image to guide our
Cutting is always manual, huh?
Cutting's always, the question is cutting manual? Is it always manual? Yes, it's a slave robot.
Yeah, that's why I call it a slave robot.
Yeah, it's a master-slave robot. There was thoughts of just developing programming or software to do surgery. That concept would not fly in the U.S. It just doesn't have traction. People don't want to rely on machines or computers. They still want the surgeon. And I think it's right, and not only just it doesn't make sense intuitively, but there are decisions that you're making. The surgeries are somewhat standard, but there's always going to be variations and decisions that you have to adjust to. No tumor, no patient is the same. So it's hard to write software to do that. The other thing that is the future, which I'm interested in, is single port. So I showed that we have all those ports that we put around. What we've started working on is going through just the belly button, taking all those 5 little red dots and just putting it through the belly button. I've started doing it laparoscopically. Robotically will hopefully be coming out. They started looking at this in Europe. At Beaumont, we started doing single port robotic gallbladders. That's the currently only approved procedure right now. The nice thing about that is it's cosmesis. You don't have any scars. You can bury all the scars in the belly button and you can't really notice that you had surgery. So it's a nice approach, especially if young women, young men who are interested in cosmesis, and that's single port. Also, the future is smaller robots. Here you can see a robot that, a test robot, but this is a robot that is the size of a dime. So we can put in multiple robots in the body and control them. That's a concept that's being looked at throughout the U.S. The robotic single port is being used in Europe. It's currently being used in the gallbladder. Here's a picture from my mentor, Dr. Kayuk at Cleveland Clinic, where he's doing robotic surgery. This is a pig, but again, putting all those ports in one through the belly button and doing surgery. This is kind of experimental stuff. We will see this in a year or two. I'll start doing this once it's approved. But again, less incisions, better cosmesis, potentially quicker recovery. The other thing that you'll see, and it has gotten a little press, but it's going to get more and more, it's something we call NOTES surgery. And NOTES is basically an acronym for, and this is the future, this is not what we're doing now, it's just kind of, what we'll see in the coming years, is natural orifice transendoscopic surgery. That's NOTES. And what that basically means is that we use the natural orifices of the body, the mouth, the rectum, the penis, the bladder, to enter the body. So we don't make an incision. We go through the natural orifices that we have. Here's a picture of taking this instrument through a guy's rectum, through his colon, and going ahead and doing the kidney surgery. The nice thing about that is you have no cuts on the body. It's truly incisionless surgery. And what the industry is developing is instruments like these. I call these like little crabs, where you have a camera and these 2 little crab instruments that will work around that, and you can control those crab instruments and do the surgery through there, through a small, it's a very narrow window that you're working through. And that's what we'll see at some point. Guys have taken gallbladders out through the stomach, put a scope, put one of these crab tubes down through the throat, gone through the stomach, and then pulled the bladder out, throw the gallbladder out through his stomach. People have taken kidneys out through the vaginas for donors. Again, incisionless surgery. Problem, what we have to get past is we're violating colons, we're violating stomachs. There's significant risk that we haven't gotten past. and there's significant potential complications. But as the technology progresses, our understanding and the equipment gets better, I think this potentially will be a reality at some point in the future. And then there's lastly robotic notes. This is a cool system that we basically use a robot, you know, it's basically a snake with the working elements at the tip, and you basically use a joystick. So you can snake this instrument anywhere in the body and do surgery. They do it some procedures in the heart right now where they'll snake this tube all the way up into the heart through the groin and, you know, ablate an area of the heart. It'll be just in due time where we start doing surgery through these, you know, through these robotic instruments. So that's the future. We'll see how it goes. Time will tell. But industry is well behind it. There's a lot of money diverted to developing these techniques and technologies. That's pretty much my talk. You know, I try to capture a little, give you a flavor of where we've started and where we're headed, and you know, and the advantages of robotic surgery for men's health, for prostate, kidney, bladder, and you know, the vasectomies. But I think as time goes on, you know, it's going to be the basis for all surgical procedures. You know, the biggest issue now is just cost. It's not cheap. So I'm just going to open the floor to questions, if you guys have questions. It's a great question, and the question is, you know, where does the oncologist come into play in surgical treatment? Where does radiation come into play? When do we use chemotherapy? What we do at Beaumont is knowing that multiple specialists are involved in your treatment, we have a multidisciplinary team where we'll evaluate each case. So we'll get the surgeon. I'll sit down with the oncologist. I'll sit down with the radiation doctor. I'll sit down with the pathologist and the radiologist, and we'll review the case. Before that, we've seen the patient and we've discussed all the issues, and we'll decide what's the best way to treat this disease. And usually, especially with bladder, it may be a combination. Typically it is a combination of chemotherapy with surgery. It could be chemotherapy with radiation. It depends on the disease. So I think a key concept, which you kind of alluded to, is multidisciplinary care. Getting everybody together and discussing what's the best way to treat this disease. Because it's not just the surgeon, okay? The surgeon is part of this team and plays a role. His opinion is valued just as equally as valued as the oncologist position and the radiation. I like working together in the teams because I see problems differently and look at things differently than a radiation guy. But together we discuss it. So there's no real conflict. It's a discussion. And we discuss discuss what's the best way to treat it. Because sometimes surgery might not be, sometimes surgery will. It depends on the treatment, but we have a discussion through these. We have these multidisciplinary clinics where we sit down and go through this, and sometimes there's arguments, disagreements, but you know, we look at what's best for the patient, whether it's a robot, whether it's the radiation or a drug. But you know, the way that medicine's going, it's a combination. It's usually a combination. So the question is, what does removing the bladder do to the life expectancy of a patient? Very difficult question to ask. It depends on how healthy is the patient, okay? You know, life expectancy is based on your cardiac risk factors, your vascular risk factors, pulmonary, how healthy you are, what's your performance status, how strong you are, but also the extent of the cancer. You know, bladder cancer is a serious cancer where you can't have a reoccurrence. So it's a combination of that, you know, and I don't think I can answer that. It's on an individual basis. And that's where that team concept comes in, because surgery is radical. It's a big procedure. Medically, can that patient tolerate that procedure? You know, if we have a complication, can he tolerate a complication? If the answer is like no, he's got some coronary problems, he's got some heart issues or some other issues, then we'll say, well, let's look at other options. Let's look at chemotherapy. Let's look at radiation. And that's where that multidisciplinary team comes into play, where everyone can kind of, you know, discuss it. And it's real collegial. I enjoy it because I learn a lot. You know, you talk with other guys and you see problems differently because we're all coming from different angles. And we usually can come to a consensus on what's best for the patient, regardless of whether it's the robot or chemotherapy or drug. The question is there, after you have your bladder removed, is there a medicine that you require for the rest of your life? And they generally no, okay? Most bladder cancer patients that go for surgery, that have their bladder removed, will get typically, and very generalization, typically 3 months of chemotherapy, okay? They'll get their chemotherapy, we call it neoadjuvant, and then we'll take them to the operating room and remove the bladder. After that, odds are you'll be fine, but it's purely based on the pathology, the extent of your disease. That's the typical. So no, once the bladder is removed and the cancer is gone, we see no demonstrative disease, we follow you. Sure. The question is about a TURP, a transurethral section of the prostate, which I referred to in the initial part of the talk was a rotor-rooter. TURP has been around for 40 years. It's one of the mainstays of prostate treatments for non-cancerous, for benign. The newest technology we're seeing with the TURP is the laser. There's a green light laser that we're using to do the TURP. It's essentially the same operation. Instead of resecting the tissue, we use a laser to ablate the tissue. What's the advantage? The advantage is you don't have to stay in the hospital. Less blood loss, less complications. You go home that day. So that's probably, there's no significant. Oh yeah, green light. Yeah. Green light's been. Beaumont just got the newest laser. It's the Moxie fiber, where we can deliver high energy in a quick amount of time.
I had that the thermal, the microwave, which basically didn't work.
The question was about the microwave. Microwave is an office-based procedure, TUMT, a transurethral microwave therapy. It works for your scenario, or clinical scenario where it didn't work is pretty typical. They work for a little bit and then they just don't work. Basically, the microwave opens your prostate a little bit, obviously not enough, and your prostate keeps growing. Prostate's essentially a donut that surrounds your urethra. So what a TURP does is just open up that donut so that you can empty the bladder more effectively. So the only new thing with TURPs right now is the green light. Is the laser energy.
Would most people qualify for that, or is there special?
Most people would. Most people would. But again, you have to have a discussion with your urologist, and gland size, gland shape is the biggest factor in that. So I'd like to thank all of you guys for coming. I really appreciate this. I enjoy talking to patients and discussing, what we can do in the operating room, and it's very rewarding because I know, patients will do well with robotic surgery. I also like to thank Michigan Institute of Urology, Run for the Ribbon, and the MIU Men's Health Foundation for supporting this talk tonight. Thank you very much. I appreciate it.